already aware, there has been a change to the way these webinars are recorded. So they will be available in the chat bar at the end of the recording. So if you went back into the chat bar in Microsoft Teams, you'll be able to download this recording after the meeting has taken place. So I'm going to give you some updates this morning. The first one I'm going to give you is about the importance of postnatal checks. So there's been some restoration of services in NHS England and NHS improvements, and it's really important that we're providing all women with postnatal GP checks, which are roughly 6 to 8 weeks after they've given birth. And there's been a significant change to the provision of maternity services after COVID and during COVID, and that's really important. Just to remind everyone that it is in our contracts to do that at the moment, and we are being asked to make sure these are reinstated. Just to give you an idea of what we're doing in our practice, we are seeing babies in their baby checks at the same time as immunisation. So they might not be exactly at 6 weeks, and they might not be exactly at 8 weeks, but around that period. So we're still doing things virtually where possible, but of course, some of the checks do need to be done face to face, particularly for babies. And they may mean that for women as well. Certainly a lot of it can be done virtually, but there may be times where you need to see these women face to face, and it might be that they're coming for their baby checks. This might be the same opportunity to use. And what they're saying is that vaccination should never stop, and they should remain as a high priority. And that's been said by NHS England, the BMA, and the Royal College of General Practitioners. Okay. I just wanted to, the next thing, a really important thing I wanted to talk about this morning was the primary care SOP. So this is updated by NHS England on a very regular basis, but there's some real key changes that I wanted to just let you know about in the last week. So what they've absolutely said, and this is some new wording they've inserted, I'm going to read it from the SOP. It says that shielded patients should have proactive follow-up to ensure they know how to access care and support, and those requiring face-to-face assessment should be seen by home visit where possible, unless alternative care settings is clinically indicated. And they added the word home visit to the SOP this time round, and that's really important. So what they're now saying is anyone that's shielding and needs to be seen face to face. So for example, if I had a patient on the phone that said I've got abdominal pain and actually they're shielding and they can't come to the practice and they're a cold patient, they should be offered a home visit. Now, as you're aware, we are still commissioning the Advanced Assessment Clinic, or also the HOT Hub as we may know it, through the Federation, who are kindly providing that, and Barndock. So they are providing a home visiting service for acute illness, so acute care, that is still being commissioned through the month of July. And so to make a referral to the HOT clinic or the AAC, for whether that's a face-to-face HOT patient or whether that's for a home visit, you should fill in the form, which is the Advanced Assessment Form, the AAC form. And then you could go on to book an appointment, so cross-organisational, just like you would book a hub or an EAS appointment, and search for the Advanced Assessment Clinic. I think it's generally good practice to put your mobile number on the referral form if you're a GP colleague, because that GP might want to speak to you. So I think it's really important to do that. And that's a real key change in the SOP that came out this week. And then they've specifically highlighted the word home visit there. The other thing I wanted to highlight to you, which has changed in the SOP, is about outbreak management in the context of COVID-19. So what they're suggesting is that in August, we're going to start moving towards more business as usual. We might have more patients coming into the practice, certainly, even in July. And so what they've said in this week's statement is to say that general practice must continue to have an updated business continuity plan to ensure arrangements are in place to minimise the impact of local incidents, including pandemic influenza. And because they're also predicting that, along with COVID, in the winter months, we're going to probably have an outbreak of influenza plus COVID. And so we need to put that in our business continuity plans. And that includes things like staff being poorly or being required to isolate or being contacted by NHS Trace and Test. And so we need to be aware of that, how we're going to be able to manage that sort of staff sickness or isolation, how we're going to do call handling, remote and patient consultation or communication, and those kind of things. Do we need to have a buddy practice? Do we need to get support within our PCN, and I think that's really important. And obviously, as the CCG, if we do have a big outbreak, we'll be communicating about ways that the CCG can help you, and whether that's where we need to step up the hot hub, or whether we need to reinstate a cold site. All these kind of things will come back into play, and be working with the GP Federation if we need their input in providing services. But what's really important, and just to add to that, is to say, if you are affected in your practice and something has happened, it's really important that you let the CCG know, and you contact the CCG for the normal reporting and escalation process, and that you also follow public health guidance on communicable disease outbreak management and any changes to your NHS contract as well. The next update I wanted to give you was about suspected or diagnosed cancers, including ongoing cancer treatment. So what they've absolutely been clear now is that we're moving towards business as usual. People are starting to be seen in 2-week wait clinics, and they're actually sort of being seen within 2 or 3 weeks now. We should continue to refer patients who fulfill the NG12 2-week wait criteria. And what's now happening in secondary care is that they are triaging and prioritising those patients that we refer in. However, they're being asked that if capacity at the sites is constrained, they need to make sure that those patients are safe. So what they will be doing is creating tracking lists. So for example, if they've asked patients to go and have investigations, like they might say, right, you need a CT, and they'll be putting them onto a tracking list, and then making sure that they're not lost to follow up, and that they're seeing them clear, and following them up. Now, what is clear is that they should have a governance process in place to see if there's any change or deterioration in the patient's condition. And secondary care continues to require consent from us as the primary care referring clinician if they want to downgrade a 2-week wait. And that's really important. So if you do a 2-week wait and they've triaged it and they don't feel the patient needs a 2-week wait, they should contact you as the GP by email, by letter, by telephone to say why they think the referral should be downgraded. They shouldn't simply return the patient to you and say this hasn't been accepted, and that's really, really important. If that isn't happening, we should be emailing the CCG quality team to let them know that there has been these issues. And then finally, patients due to begin or undergo cancer treatment will consider with their oncologist whether to start or continue the treatment during the pandemic. And some patients may wish to defer treatment or referrals. And what's really important is that in practice we follow a safety netting procedure, and we do have ways internally to follow up these patients. If you say to somebody, for example, I think your skin lesion needs a 2-week wait, and the patient says, sorry doc, I don't want to go to the hospital right now, how are we going to follow that up? Because patients might say, I don't want to go to the hospital right now, don't refer me. I mean, I've had that, and I've tried to convince patients that actually it's really safe to go to the hospital for a 2-week wait, and the benefits outweigh the risks. And often things are done in a really safe environment. But some patients who might be shielding and might say no. So do we have a mechanism in the practice to say, right, I'm going to call you back in 3 weeks, 4 weeks, to re-explore whether you want me to refer you? But be reassured that when we refer the patient to the hospital, they maintain a clinical burden as well. And so once they've done the referral, they should have a governance process in place to make sure that patients are safe. If there is a deterioration in that patient, if they're waiting several weeks for a test or a face-to-face, that they're organising that. So they're all my updates this morning. I'm going to stop there. If there's any questions from anybody in the bar, or if anyone wants to speak up or use the hand bar, do let me know. We've got about a minute or two for any questions. If you do think of any questions between now and Friday, again, just pop them into the chat bar. I will pick them up between now and Friday, and we can talk about them on Friday. Is there any questions from anybody at all? Okay, great. Well, have a good morning. I hope the weather isn't too bad today, and I'll see you all on Friday. Thanks for joining me this morning.